if you have any particular issues. We're not going to treat these things, but just to sort of talk through complaints that patients might have. And so if we can just restrict it to not your patients, but yourselves. Anybody have any ongoing issue that might be addressable by Chinese scalp acupuncture? Tennis elbow. Okay, so who would like to talk about how we would address tennis elbow? How would you approach that from a CSA standpoint? Okay, so the first thing to do, we have an upper extremity problem, and it's the middle 2/5. Which side? Which side is it on? Okay. Okay, so you would do the middle 2/5 of the right side, and that would require probably 2 needles to get that, length needles, to get that entire middle 2/5. Okay. All right, so that's one thing that we could do. All right. What else? What if that didn't work? All right. We could put, you can also put more than, when I'm saying 2 needles, I'm talking about to get the length of the middle 2/5. It's probably going to take the length of 2 needles to get that entire thing, is what I'm saying, rather than just 1 needle. Okay? So you may want to do that, and then you may also want to accentuate that treatment by putting another needle or 2 in the middle 2/5 of that left side, right? Like we did when we were treating the leg problem. All right? And then what else would we do? Okay, if we weren't having any luck, we could do the same thing that we did with the leg, right? We could put a motor, we could do the middle 2/5 of the motor, and then we could go switch over to the ipsilateral side and do the sensory, the same sort of thing that we did with the leg. Everybody follow that? And then we finish the treatment up always with foot motor sensory bilateral, right? Okay, good. So tennis elbow, a way to approach tennis elbow with CSA. Who else has a problem? Question?
So anytime you're doing in a 2/5 section, do you do 2 needles in each of those? So you're doing 2 in the contralateral section, 2 in the contralateral motor, and 2 in the...
To cover the middle 2/5 or the lower 2/5, it takes a good length of needle to get through that. And remember, your needles, your 4-centimeter needles are really only, they're not really quite that long. And so to cover that whole thing, now you can look at the homunculus and see that the hand is the biggest chunk of that middle 2/5, right? And so if you're treating an elbow, you can err on the side of going up to that second 2/5, if you will, rather than those middle 2/5, to get more just into the elbow area. But to get the whole thing, you're probably going to take the length of 2 needles. Okay? What other problems? No other problems? Insomnia. Okay, well, we're going to come to that later on. We'll talk about that later on. We haven't gotten to that yet, but we will get to that later this afternoon. What about musculoskeletal problems? The things that we've already learned about, sensory and motor areas.
Intermittent low back pain.
Okay, intermittent low back pain. Okay, is this you? Okay, do you have sciatica with it? Just low back pain? Is it right or left-sided? Pretty much midline. Okay, so who wants to tell me how we would address that? Right, and that's the key thing. Right. Okay. Okay, so you could put 1 needle bilaterally in the upper 5th of the sensory. You can reinforce that, and then you could go to motor if you don't get that. And you're already ipsilateral, so you've got it covered. And then you would follow that with foot motor sensory. All right. What if you just had right-sided back pain? What would you do? I'd do the same thing. I'd do it all bilaterally anyway, even if they were complaining primarily of right or left-sided back pain or neck pain or whatever. Okay.
That would be different if it had sciatic symptoms?
No. Would it?
I don't think so.
No, I wouldn't either. Right. Yeah, I just asked. No, I don't think it would be any different. Okay, anybody else have any particular problems that we might want to address? Ongoing complaints, past complaints? Joe?
With permission, I'd like to editorialize that in saying this, as you know, kickback, kick neck, headaches are the biggest three time out MLP issues in the CSA, and what has knocked down the lot of time if you get to it early. And to be prepared to offer CSA, crystal, and often business as well. So be prepared to something to yourself, have them walk, have them test them. Start with the number, do it, test it, see where they are, add more. At a certain point, you've exhausted your CSA laboratory, then go to ear. And go to ear. If you have enough time, if necessary, go to surface relief for some of the next. If you don't, you're going to have to go back for a follow-up treatment. You want to do something aggressively with managing kickback and headache, so that it doesn't come into being. Don't just walk away saying, this is yours. Work with them, test them, force it, work with them, walk them, and add something to it.
Okay.
This is every day, bread and butter. If you were in real life, this is how you make your business.
Any other problems that we have or any questions up to this point? Yeah.
I had a patient last week with TMJ. We were talking about the face, as far as facial pain yet.
Mm-hmm. So what do we know about, is this TMJ both sides, one side?
I can't remember. I
Okay.
think it was predominantly one side.
Okay, so if it's one-sided, you'd obviously be on the contralateral side, right? And then we have an upper 1/5, a middle 2/5, and a lower 2/5.
So
which-
probably lower 2/5.
Lower 2/5, right? It's the face and the head is the lower 2/5. All right? Now there are other ways that you can address TMJ as well that you'll get to as we go through the course, but this would be one way to do it. As Joe said earlier on, the further down you get into the middle 2/5 and the lower 2/5, you have the temporalis muscle to deal with. And that requires a little bit more careful needling, because if you get into the temporalis, that can be pretty uncomfortable. Okay, so, but not to say don't do that, but that's the area that you would use on the contralateral side, and then always finish up with foot motor sensory. So it's really as long as you have an understanding of how, you have an arm problem, you have a leg problem, you have a back problem, a neck problem, what would you do? It's really pretty straightforward, right? And as Joe has said, most of what you're going to do is going to be from the neck down, excluding the arms. That's most of the body is going to be the upper 1/5, which is the easiest part to do. Alan.
With TMJ, when you guide for it, even though it was symptomatic on one side, I've always treated it on both sides because it's trying to recreate a balance between both sides of the thing. So, don't you think of using scalp bilaterally as well?
Well, sure. Yeah, I mean, you can't go wrong going bilaterally. I think that's true. When you have problems that are fairly midline, which TMJ kind of is a fairly midline problem, and certainly it's frequently a bilateral problem, even if it's more one side than the other, and you said you thought it was more one than the other side. So sure, you can't go wrong. It's just a few more needles. Okay. Any other questions or problems that anybody has that you might think about with scalp? Doug? Stroke. Well, that would depend on, what would it depend on? The symptom and the side of the stroke. Okay? Who's seen a stroke patient recently? What was the patient like? Okay? Well, those are areas that Joe mentioned earlier on that we're not going to do too much with. There are 3 speech areas. You can read about that, and I think you've seen some lectures. So if it's mostly that, again, this would be a bilateral treatment if it was a speech issue, most likely. Okay?
I think when we were putting that criteria together, consulting with Nick, the issue with receptive symptoms are. Cover your bases. Am I better than enough to it? I'm better.
They had also called one of them directly.
Yeah.
So I think the one that was at the bottom of the motor line,
That's just motor aphasia, so the person who is not fluent, I think you can start with that one. That's all. Okay. The others, combined.
you're okay.
Yeah, the wording in the video is consistent with what we talked about during all of those, Jason, how irregular is the sort of thing. Okay. So, that's what you work with. And you do it. And with those, with the folks you need to work with that too. It's not a one-off thing. You need to be, the patient needs to be able to come in, you need to be able to see the patient in some way that I already, even for 3 times a week at the beginning of the treatment, until you see how far you can go.
And then stroke, of course, you're going to be much more attentive to the motor sensory than, well, not maybe more so, but certainly more so than you would with pain problems, as an example. Right. That brings up a good point, though. Talking about back pain, it's obviously a pain thing, so it's a sensory issue. But almost all back pain has a motor component, right? So it's a good idea to get into the habit of using that motor line on the contralateral side with most of the pain problems, because there's going to be some motor component, even if it's only tension to keep the pain at a minimum, holding some body part in position, something like that. Okay? Any other comments or questions?
I think thinking
Oh.
on motor aphasia that you consider KB points. KB points as well as steps. I mean, I've had some experience with that the KB points are helpful in restoring motor function.
Well, you said motor, you didn't mean aphasia? You didn't, like a hemiparesis? Oh, right, sure.
I said aphasia.
Yeah, I was trying to figure out KB points with aphasia. Right. That's what I was saying. I think with stroke patients, a lot of it is motor stuff.
Yeah, right.
Yeah, exactly. Any other comments? We're going to talk about tinnitus. Funny you should bring that up. And this is a good, probably, segue into tinnitus. So what we're going to do, what I'm going to demonstrate is 2 more areas. One of them is the hearing vertigo area, which is above the ear, okay? And the other one is the balance area, which is in the occipital area. And then Mitch is going to talk about frontal triangle and the temporal fans also. All of these are commonly used in TBI patients because frequently they have issues with tinnitus, with balance, with vertigo, those sorts of things. So these are areas that you can bring to bear on your TBI patients. So the area I'm going to talk about is this, first is the hearing vertigo area here, right here above the ear. The way you find this is to find the apex of the ear, the highest point of the ear, and go up from there 1.5 centimeters. Okay, and that's the midpoint of your hearing vertigo line. And then 2 centimeters anterior and 2 centimeters posterior to that, for a total of 4 centimeters, is the hearing vertigo line. When you're using the hearing vertigo line, pretty much always you'll treat it bilaterally. All right? It can be useful for things like, not so much for hearing. I don't think Jason has had a whole lot of luck with hearing, but more so vertigo, dizziness, tinnitus, Meniere's, those sorts of things. I don't know that he has any luck with hearing on that, does he? Yeah, I didn't think so. So, but nevertheless, I needle this with 2 needles, and you can. What I would do, this is the left side of the patient's head. I'm right-handed, so I would needle. What I would typically do with this is start my first needle at the midline or at the midpoint, and direct it like this, and then I would start another needle 2 centimeters back, and direct it like that. So, on the left side of this patient's head, because I'm right-handed, the needles are going to be going in this direction. If you turn the patient around, I'm right-handed, but the needles are going to be going posteriorly. Does that make sense? So unlike foot motor sensory, which both run A to P, these can go in either direction depending on if you're right or left-handed. You need to cover the 4 centimeters. Okay? Mitch and I were talking. Mitch, you like to use one needle for that? Say? My problem with one needle, the hearing vertigo area is over the temporalis muscle. And the farther you push a needle in, the more likely it's going to dive down, at least in my experience, into that temporalis. So I try to eliminate that as much as I can by using 2 needles to cover that distance rather than 1. Okay? And then we have the vision area up here, which we're not going to really talk too much about, but we have the balance area. And the balance area, obviously for balance, but particularly for the folks with TBI that have their equilibrium issues and that sort of thing. The balance area, it says here 4 centimeters from the midline, anywhere from 3.5 to 4 centimeters from the midline, starting from the occipital protuberance, directly on either side. Again, you're going to use bilateral treatment for this. And the needle is placed superiorly and aimed inferiorly on both sides. Now this is one that I would tend probably to use just 1 needle to get it as far as I can, rather than 2 needles. It may not go the whole distance, but that's probably okay.
So here you're going into cervical musculature, and it's really tough to stay superficial. Fortunately, the cervical musculature is not as generally innervated as is the temporalis. So you shouldn't have too much trouble. Mind you, I mean, with the balance area, clearly you're overlying the cerebellum. So again, when you get the needle displayed, how does it not go to the head back? The reason we wanted to emphasize the hearing vertigo and the balance area is that in your pediatric hip trauma patients, you're going to have balance problems, you're going to have vision problems, and across the field, certainly in a military environment, with the noise and such that you're dealing with, you will have tinnitus. There's lots and lots of tinnitus in the universe, in your universe. For tinnitus, use the hearing vertigo line, which will be very helpful. But with tinnitus is not just middle ear issues, but it's also all of the muscles that are surface concerning. You've got some jerk-around trauma sensations from carrying kids, from doing taking out of airplanes. All of that needs to be worked with appropriately with osteopaths, with surface needles, with people needles, along with the scalp when you're trying to create treatment. It's not a one-stop shop, but you can make it much more tolerable by having a proper treatment. Okay. My practice is not consistent with the way you're obligated to practice, because I schedule my patients every half hour. I can keep them in. I've got 3 rooms that I work. I have people helping me, clinical people helping me, so I can spend as much time as I want with the patient or as I see as it's necessary. I also see patients repeatedly, have known many of them for years and years. So when I'm doing scalp, and I have the confidence of the patient, I'll say leave these needles in for 4 hours. If they can stay in longer, fine, but try to leave them in for 4 hours. And pretty much I get pretty good compliance on that. The longer, the better. If you watch Jason Howe, did you see any of Jason's treatments on the videos? And I think we edited most of that out because his English is so difficult to follow. We spared you that. Jason is he's very dexterous manually, and he'll work the needle as soon as he gets it in place. He's claiming he's doing 200 turns a minute. Well, that could be exaggeration, but Jason tends to hyperbole when he's talking about his skills and his successes. Nevertheless, he works his needles pretty vigorously before he lets them sit. He lets people sit for maybe a half hour and goes back and works them 2 or 3 times during that process. That's a good thing to do if you can at least give them a turn to keep it going. Minimum time for scalp is a half hour. You really need to leave it in long enough to have an impact. I don't do a lot of twirling other than what I said. 2 or 3 times during that first session, I do it, or during that first half hour, I do it. But if they're going home for 4 hours with it in, I just let them do it, instruct them about taking it out with a cotton pad, and so on. And I get very good results with that. So for you, it depends upon how confident you are with your patient as to whether you want to leave them in or have them stay in the waiting room for a half hour, come back, or have the techs take them out. If they can stay an hour, even better. As long as what they're doing doesn't bother. But if, for example, you've got the hearing vertigo in place, mastication or talking or laughing can be unpleasant. Just tell them to not laugh, or deal with the consequences. It's common sense will lead. Common sense will inform them what not to do. It really is just stretching the muscles where the needles are placed, and they'll back up from that. But otherwise, no. Just make sure that they have a cotton or a Kleenex to dab the blood when they take the needles.